Dr. Schwell, I'm going to send the first question your way. I've heard some people say that COVID vaccines aren't necessary for relatively young people who are in good shape and don't have medical problems. What are your thoughts on this?
Well, Kyle, as you may know, I'm a critical care intensivist and I take care of patients in the hospital. I work in a one ICU hospital in a one hospital town. So anything bad that happens comes to me in the intensive care unit. I'm the one that is there when they put the endotracheal tube in. I put the chest tubes in, the central lines, and holding the patient's hands. And so for me, in the last couple of weeks, this has become really personal for me because what I've seen in the last couple of weeks in our hospital is like nothing else that I've seen, even with the prior wave going back to February and January of this year. So what is it that I'm seeing? I'm seeing patients in their 30s, patients even in their 20s coming in with very few comorbidities, maybe just a little bit overweight, and they are ending up on the ventilator. I've seen fathers in their 60s coming in crying, asking me to do everything that we can for their sons who are in their 30s, newly married with small children. We didn't see that back in February. And so to get to the root of your question is what do people who are younger have to be concerned about? I think it's a very good question because all of the things that we have learned about COVID-19 in the past is now being rewritten by the Delta variant. So if you look at some of this data, this is data from Virginia, and you can see here on the left-hand side of the screen in January is a graph that we're all very familiar with. This is basically the monthly hospitalization rate by age group. And what you can see there is on the right side of that first graph is it's a very high number for the elderly, and it goes down very precipitously for the young. And that's because the young were not being hospitalized. But as we go across this screen, you can see here that when we end up in August, a very ominous sign is occurring. What we're seeing is that the younger population are being hospitalized at almost the same rate. Instead of a 20th or a 10th, it's maybe half of the rate of the elderly. And so why is that happening? Well, we know that there's a very high vaccination rate in the elderly and a relatively low vaccination rate in the young. Even look at you can barely see it, but the yellow boxes are describing what's happening to pediatric cases. Pediatric cases, of course, those less than 12 years of age who can't get vaccinated are skyrocketing. And so this is the concern that I have. We look at some of these other issues, for instance, this idea of the 99% survival rate. That's something that they say, hey, 99% survival, and I really don't need to be concerned about it. So if you look at this data and we compare it to something that we know very well, like the flu virus, you'll see here that the hospitalization rate for the flu virus in young people is about 0.01%. If you look at the pre-Delta COVID-19 data, it's about 0.2%. So it's almost 20-fold higher for COVID-19 in the young than it is for the flu. Now, if you think about the 1% number, there's only the 1% that are going to be affected. That won't affect me. What we are seeing right now in this country, especially in states like Florida and Texas and specifically Idaho, is an overwhelming of the critical care hospital healthcare delivery system. Think about this. The population of the United States is 331 million people. If just 1% are going to die, that's 3.3 million people. And that's just the people who are dying. Let's talk about the people who are sick and need to be hospitalized because they can't breathe because of oxygenation. We only have under 1 million acute care beds in the United States. And so as a result of that, you are going to quickly overwhelm the healthcare system. Let's take the state of Idaho. It has a 39.7% fully vaccinated rate. And what we're seeing there, as of yesterday, the governor has declared that hospitals now, because they're overwhelmed, are going to start to deliver basically rationed care. You should not expect the same standards of care that you're used to expecting in the healthcare delivery system because they're just not able to give it. Let me give you some specific examples. Instead of having one intensive care nurse for 2 patients, it's now going to be one intensive care nurse for 6 patients with some help from non-ICU nurses. Because they're overwhelmed, you cannot transfer patients to higher level of care for things that they need to get done, if they have very advanced cancers, for instance, because those hospitals don't have room. If you need elective surgery, their elective surgeries are being canceled. Traumas are still happening. Babies are still being born. These are the problems that we're having in a situation where you may think that because you're healthy and strong and young, you're not going to be affected. But if you were to get into a car accident, or you know somebody that wants to deliver a baby and has a complication, it's going to be difficult for those things to happen. And so this is the thing that's occurring. And going back to my experience in the last couple of weeks, every single one of those patients in the hospital that were there in their 30s, their 40s, were not vaccinated. And it's based on information that's coming out that you're making decisions based on whether or not you should get the vaccine because you hear about side effects or you hear about things, for instance, about myocarditis.
Well, here's an article from the New England Journal of Medicine, peer-reviewed, published September 16, 2001, looking at the Israeli data with almost 1 million subjects in each arm. So what we have here plotted in yellow is the risk difference per 100,000 persons infected with SARS-CoV-2, and in blue is the risk difference per 100,000 persons who received the Pfizer-BioNTech vaccine. First, let's take a look at SARS-CoV-2 or COVID-19. We see big risks here for acute kidney injury, for arrhythmia, for deep venous thrombosis, for pulmonary embolism, and for myocardial infarction. And again, notice that there is a small signal here in terms of COVID-19 for myocarditis and pericarditis. Clearly, there is a small signal there with post-vaccination myocarditis and pericarditis, but actually the data here on these from Israel is showing that it's more likely to get myocarditis and pericarditis post-SARS-CoV-2 infection. But in terms of the relative risks for the vaccine, which is in blue, notice that the biggest one here at 78 is lymphadenopathy, which is a normal response to the vaccine. Now, there's been a couple of papers that are in the peer review process, but have been published to a medical archive server. And again, the peer review process is where the paper is submitted to experts in the field that review it, looking for possible bias or things that were not taken into consideration. And this preprint, non-peer-reviewed article using electronic records in the United States also agreed with the Israeli data that was published in the New England Journal of Medicine and came to the conclusion that young males infected with the virus are up to 6 times more likely to develop myocarditis as those who received the vaccine. Another preprint, which is still currently in the process of being peer-reviewed, made headlines in a number of papers in the UK and also in the United States. And it showed the opposite, that the incidence of post-vaccine myocarditis had a higher incidence than hospitalization in pediatric patients from COVID-19. However, the article gleaned most of its data from the VAERS, which, as you know, is a reporting system and raw data based on reports that could be made by anyone, and often contain incomplete descriptions and chart notes that require additional investigation, removal of confounding variables, and comparison to background levels of medical problems to become useful. Now, we'll talk about the VAERS here in just a bit, but as you'll see, VAERS data doesn't allow you to really conclude anything. VAERS can be used to generate hypotheses, but not to test them directly. So in summary, I think it's good for researchers to generate hypotheses from VAERS data, but it's a problem when newspapers turn hypotheses of observational data that haven't been peer-reviewed yet and turn them into headlines. So it'll be interesting to see what issues the peer review process points out in these papers and if they go on to be published.
So to answer your question, Kyle, there's a lot of information there, but for a young person now, today, facing the Delta variant and maybe future variants, it's not the same type of virus that we were dealing with back earlier in 2021. Yes, now they are more susceptible to getting the infection, and now the risk of them being hospitalized is higher.
Dr. Patrick, what are your thoughts on this question?
Well, I think in addition to hospitalization, there's also the risk of people who have mild symptoms who don't have to go to the hospital. They stay at home during the duration of their illness, are coming down with post-COVID syndrome, which is popularly known as the long haul COVID. And the symptoms range from brain fog to racing heart problems to lethargy. And there's been a variety of studies that have come out that have looked at, what long haul COVID is and what population it seems to be affecting. And interestingly, you'd think, well, people having these long-term effects would be the ones that were, on the ventilator. Well, of course, people on ventilator do have long-term effects, but you'd think people that are hospitalized would be the ones mostly having these long-haul COVID effects. And it turns out younger people under the age of 50, teenagers even, people in their 20s are the ones that are really, coming down with this long-haul COVID syndrome. There's a preprint that has not been peer-reviewed yet, and it's a big study that was done out of the UK, and it's part of this ongoing study called the Biobank study. They get large population sample sizes. In this case, it was close to 800 people. It was 780 or something like that people before the pandemic came in and had MRI brain scans. And so they have all this, there's researchers have all this data on individuals, brain structure and volume. And so once the pandemic hit, many people came down with COVID-19, some mild cases, some more severe, some were hospitalized. And a few months, into the pandemic, researchers doing this biobank study thought, hey, we should bring these people back in and get a brain scan and see if there's any changes. And so that's what they did. Just, months after their first scan, they brought them back in for another scan. And what the preliminary findings, again, that are not peer-reviewed yet, showed is that there are major differences in gray matter regions of the brain. Gray matter atrophy is occurring in several different regions of the brain, very prominently in the olfactory region, which makes sense because, one of the telltale symptoms of COVID-19, at least pre-Delta, was loss of smell, loss of taste. And also there's atrophy in other brain regions involved in memory and learning. People that had severe COVID do have worse atrophy compared to the people that only had mild cases, did not need to be hospitalized, but they themselves were also experiencing brain atrophy. These are people that did not have to go to the hospital. And of course, people were matched for the same age, the same gender, the same ethnicity, and the same time in between scans. So trying to keep everything, as comparable as possible to compare apples to apples. And so to me, that was quite frightening because it really suggests that, there are complications and there are, long-term effects of this virus that we don't quite understand and that are affecting, hundreds of thousands of people. I personally know quite a few.
Dr. Seheult, anything to add on the long COVID front? Because I know that's a concern. That's a concern that I have at my age. If I got COVID-19, would I have lingering symptoms? What are you seeing on your end clinically regard to that?
Oh, yeah. So in addition to me working in the intensive care unit, I also have an outpatient pulmonary clinic, and I've diagnosed at least 3 or 4, just off the top of my head, blood clots in patients who went to the hospital, had COVID-19, survived, got better, so they weren't part of the 1%, but then they had persistent shortness of breath, leg swelling. We immediately made the diagnosis and put them on blood thinners. And so that's just a small slice of what we're seeing in terms of comorbidities.
To add on to the blood clots and strokes, there was a study, multiple studies, one out of Israel and a couple out of the United States, showing that people under the age of 50 were coming in to the emergency room for strokes. And one of the studies out of Israel found, because they test everyone for COVID-19, a great deal of a high percentage of the people that were coming in for these strokes, these young people under 50, had COVID-19 and didn't even know they had it. So, I mean, we're talking obviously mild cases, potentially even asymptomatic if they didn't even know they had COVID-19. And they're coming in with strokes.
Yeah, absolutely. And so this is the thing, is that COVID-19 has many different ways of affecting the body. The one that we all know about is the lungs, of course, because it can cause inflammation in the lungs. But as Dr. Patrick points out, there are blood clot issues. So blood clots to the lungs can also occur, but also blood clots to the brain, which manifest as strokes.
Dr. Seheult, could you also speak to this question that some people have, or really the interpretation of something that's on the CDC website about death certificates, and how at one point only 5% of death certificates had only COVID-19 on the certificate. I know you fill out quite a few death certificates in the ICU. What are your thoughts on this idea, and what can we really interpret from that?
Yeah, so it really boils down to how the death certificate is filled out. Generally speaking, the way the death certificate should be filled out when somebody dies is you have the most proximal thing occur at the top line, and that would be, let's say there was a car accident. Okay, you were in a motor vehicle accident, and as a result of the motor vehicle accident, there was a rupture of one of the internal blood vessels, and then you bled out. So you wouldn't just put at the top of that death certificate motor vehicle accident. That's not what the Bureau of Statistics of your state wants to see. They want to see ruptured, pulmonary artery. And then under that, they want to have the reason for the ruptured pulmonary artery. That would be motor vehicle accident. So when you are describing somebody with COVID-19, you don't die from COVID-19, right? COVID-19 is not a final cause of death. It may be the thing that set things in motion. And so you would have COVID-19 caused pneumonia, and then that caused something like acute respiratory distress syndrome, and that was the cause of death. Because as we've just mentioned, COVID-19 can cause death in many different ways. COVID-19 could cause you to die by a pulmonary embolism or a stroke in the brain. Unfortunately, some physicians are just putting COVID-19 at the top. So I think, Kyle, what you're referring to is this statement that we see here on the CDC website. And they say here that, quote, the number of deaths that mention one or more of the conditions indicated is shown for all deaths involving COVID-19 and by age groups. For over 5% of these deaths, COVID-19 was the only cause mentioned on the death certificate. So people have taken that to mean that really COVID-19 only caused 5% of the 600 plus 100,000 people that have died in this country, and all the other things were just comorbidities. But if you actually look at the CDC's website, you'll see what some of these, quote, comorbidities are. And as we've just discussed, they're the actual way that COVID-19 kills people. So, for instance, the number one comorbidity was pneumonia. Influenza and pneumonia are grouped together. Well, the pneumonia was caused by COVID-19. It wasn't a comorbidity. Another one that's very common is respiratory failure. Yeah, it's not like people are coming with respiratory failure and they also happen to have COVID-19. No, COVID-19 causes respiratory failure. And another one of these ones that was on there was adult respiratory distress syndrome. That's actually what they mean to say there's acute respiratory distress syndrome. Again, another thing that's caused by COVID-19. And so what's happening here is that these physicians are very busy. They're being handed death certificates. They need to fill these things out. They think, oh, yeah, that guy, he died of COVID-19. That's right. And they just write COVID-19 at the top. That's the incorrect way of filling those out. And that's the reason why, fortunately, only 5% of those death certificates are being incorrectly filled out with just COVID-19.
Just to clarify, using that data to make a case that really COVID-19 is only killing people with multiple comorbidities is not accurate.
Not at all.